Welcome to the show that brings the living experiences of black men in the UK in a dialogue of equals with health professionals from the NHS and community advocates to reduce health inequalities affecting our communities.
Me and my unks had a dialogue of equals. We're tired of all our people dying before they seem to. Silence don't make you peaceful. So many open wounds, don't even know how we'll heal all. But this is food for thought of a meal. It might be a free course.
Greetings, and here we are for another episode of the amazing podcast, Dialogue of Equals, where me and my co-presenter, Michael Morgan, Stafford, Scotland, we're representing on behalf of the brothers out there.
Yeah, I still like to think of myself as a backup dancer because you are in the forefront of this. You are actually doing the heavy lifting. I mean, look how many facts and figures you've been bringing to the table. I'm just here to back you up.
I'd like to think that we have some really amazing professionals from within the NHS who are able to really give us all the professional stats that we need here. So they're the ones I'm really reliant on. I've had a bit of experience around this agenda, and because we've been in partnership with Dr. Sarah Paparini from Queen Mary's University, we've all been learning as we go along.
So you talk about the agenda, though. What's on the agenda today?
So today's episode is called Sooner Rather Than Later, when we're going to be talking about the benefits of early diagnosis and challenges to awareness and access. We're going to actually, in this program, focus on cancers, mainly on prostate cancer. And we're going to focus on prostate cancer because it's one of the number one killers of black men today.
I would say it's brilliant we are focusing on cancer, but I think that I would be slapped across the chops if I didn't mention that early diagnosis in mental health is equally as important. And in a future episode, we will be covering mental health specifically, and we're going to go into detail with that because black men in particular are 4 times more likely to be sectioned, to be detained under the Mental Health Act. And I think that's a really important thing to put out there because had there been earlier diagnosis, that would have been given that person access to healthcare, access to CBT, cognitive-based therapy, access to medication, as opposed to fast-tracking them to detention.
I think ultimately what we're trying to say to all the brothers out there, to everybody in the community out there, but particularly to the brothers because they're a bit reluctant in coming forward sometimes, is that early detection, regardless of what the condition, early detection saves lives, and it means that there's less intervention required if you find your ailment earlier. So I will say right across the board, it's ironic that you said that you're 4 times more likely to be sectioned, right? Because there's also a 1 in 4 chance as a black man, we will we'll get prostate cancer. Okay, even worse, even more alarming, there's a 1 in 12 chance that we'll die from it. That means all brothers out there who are in football teams or whatever, 1 of every member of your side might die from prostate cancer unnecessarily. So without further ado, sooner rather than later, the benefits of early diagnosis and challenges to awareness and access. I'm really pleased to introduce our guests, Professor Prabhakar Rajan, Lloyd Gardner, and Brother Derek Brown.
Welcome, gentlemen.
Thank you, Stafford. Michael, it's a great pleasure to be here. Stafford, always entertaining and informative to spend time in your company. So I'm really happy that you've invited me to talk about prostate cancer here. So as you said, I'm a professor based in central London, specialising in prostate cancer research and also a consultant, urologist and prostate cancer specialist.
That's quite a mouthful.
It is. But the main aim of today's conversation, as I understand it, is to talk about prostate cancer, dispel some of the myths and improve the understanding of prostate cancer amongst the community.
Just stopping on the myths, if we could just adjust some of the facts. What Stafford just unpacked there, ever so slightly, was that you have a 1 in 4 likelihood that you will die from prostate cancer if you are a black man.
1 in 4 likely that you'll get prostate cancer, and 1 in 12 that you'll die from it.
1 in 12 that you'll die from it.
So I can summarize some of the facts for you. So as you've said, prostate cancer is the commonest cancer amongst men in the UK. About 50,000 men are diagnosed each year with prostate cancer, and around 12,000 die from prostate cancer each year. So the lifetime risk of developing prostate cancer is 1 in 8 for most men.
Right.
But if you're from Black African or Black Caribbean background, your risk is 1 in 4. So you're twice as likely to develop prostate cancer.
Why is that?
I mean, that's a really interesting question. And I think we don't really know the exact answer for that question. There's a lot of research that's going on in this space to try and determine why that is the case. It's a question that Stafford asked me when we met recently as to what the reasons are. And there could be a variety of reasons. It could be that patients are being diagnosed later. It could be that there is something in the genetics of the disease that puts patients of a Black African or Black Caribbean background at increased risk.
So do you think that diet has anything to do with, I know we are, proposing ideas because, as you say, it's not definitely known, but do you think diet plays a factor in this at all?
So diet, obviously leading a healthy lifestyle, having a healthy diet is good for you generally all around. It reduces the risks of all sorts of different diseases. So there hasn't been a really strong link between diet and prostate cancer risk in the same way that there has been, for example, with obesity and cancer risk, or certain types of meats and cancer risk, or smoking and cancer risk. I suspect that diet probably does have a part to play, although we haven't really found the exact causes. But the recommendation all around is try and eat a healthy diet and live a healthy lifestyle.
And again, just in terms of like myth busting, I was having this conversation with my mum literally days ago, and she was saying, the biggest scars is because stress is what causes it. And I'm thinking, well, how much of that is true? Because this is just my mum talking. She's got no medical background, no medical training, no medical understanding, but she's talking about the fact that stress does play an important factor, particularly when you put in there racism. Racism is a very, very big motivator in terms of engendering stress.
I mean, it's an interesting point, and your mother might have a real argument here that stress might be a factor. Now, if we see in the statistics now, the cancer rates are going up, and there's the number of different cancers that are being diagnosed in younger patients. And why is that? We're not too sure what's going on. It could be related to modern lifestyle, mobile phone, social media, the impact that has on our bodies and our minds. We don't know the answer to those questions, but it's an interesting point that she's raising.
Okay. I know we've alluded to the issue of risk. We know that there is genetics risk, that if your father, in my case, my father died from prostate cancer 20 years ago, and I've been told as a result I need to really take my prostate health really seriously. What can you tell us about this genetic risk, and why does it exist, and why in certain populations more than others?
So, I mean, perhaps for the listeners and the watchers out there, we should probably try and explain what genetics means, or what a gene is. So within every single cell in the human body, there are molecules called DNA. You inherit that information from your parents. And these molecules, the DNA, they are represented by letters. And those letters read like a recipe book for what the cells should be doing in the human body. Now, in cancer, what happens is the cells start misbehaving. They grow, they spread to other parts of the body. They don't behave the way that they should be behaving based on the recipe book. And the reasons for that are that there are some spelling errors within that recipe book. And those spelling errors can be inherited from families. So you may have heard of the BRCA gene, for example, that's associated with ovarian cancers and breast cancers. And these are inherited amongst the female members of the family. So it might be that there are some inherited genes, but we don't know exactly what they are yet. And there is some research that some of my colleagues are doing in London to try and understand what those genes might be.
Okay. I mean, the next question that obviously follows, but you may not be able to answer this, is why are those genes more likely to be found in black men?
Yeah, we don't really understand the reasons for that. We don't even know what those genes are if they do exist. And that's why the research is so important.
Is there a difference between the amount of cancer, prostate cancer in particular, that's found in black men in the UK and maybe, let's say, America, as opposed to the amount of cancer, the prostate cancer identified in black men in the continent of Africa, as an example?
So there has been some research that's been done on this. And what the researchers have found is that black men might present with more aggressive forms of prostate cancer. But what we don't know is whether that's because they're just being diagnosed later on in the course of the cancer growth, or whether there's something intrinsic to that cancer that makes it behave more aggressively. Of course, a lot of our understanding of genes and genetics relates to the lineage, so where people originated from. And you talked about Black African and Black Caribbean ancestry patients and how they may be linked in terms of their cancers or different in terms of their cancers. And there's been some research that's been done in that area in enough detail to try and understand the genetics of what might be going on.
I wouldn't mind delving into the barriers that we face, or whether they are self-imposed barriers when we're talking about the lack of an early diagnosis and the fact that obviously if it is diagnosed early, it can be treated. I just wondered, from your personal point of view, what you see across your desk, what are the kind of I just cut to the chase, excuses that you're hearing? Well, why are we here now and why haven't we been here before?
And that's a really good question. And one of the challenges is that in what we understand of prostate cancer, and prostate cancer historically has been a condition that we say only really affects old men, not younger patients.
Mm.
But amongst the patients that we see in East London particularly, we found that black men are diagnosed at a younger age than other ethnic groups. So it could be that if we think about what black men are doing, they might be thinking, well, prostate cancer is an old man's disease, doesn't really matter to me, I don't need to worry about it, move on. And the second thing, and I mentioned about dispelling myths, is in how we diagnose prostate cancer. And the prostate is this tiny gland that sits just underneath your bladder, in front of your rectum and behind your pubic bone. And historically, the way that we used to diagnose prostate cancer was an examination, a rectal examination. It's invasive, it's painful, and it can be quite humiliating. So that puts a lot of people off, say, well, I don't want to get my prostate checked. I don't want to go to the doctor and have the doctor examine my prostate. So that could be a barrier as well.
Mm-hmm. And other barriers, as we know, lack of awareness of the need to know in the first place, especially for underserved groups. So if people are not getting the information from within the system that we need to come and get those checks, then people are not necessarily coming for those checks early enough point.
Yeah, and many black men I see in my clinics are not aware that they are 1 in 4 risk, that the risk is that high. And there is a family history risk as well. So if you have a brother or a father who's been diagnosed with prostate cancer, your risk is also 1 in 4, as compared with 1 in 8. And Chris Hoy's diagnosis recently is an example of where family history is really important, and awareness or lack of awareness can have a significant impact.
Beatrice Troy's family, did his dad have?
I understand he's got a strong family history, but I don't know the details.
So that just says to us again that if you know that it's in your family, that you should be going forward for getting testing. But some of my friends, when I ask them about why they don't go and get tested, what they talk about is there's a fear. There's an issue about not knowing and then losing control of the consequences when we're actually diagnosed. That means the system takes over. And if it's a system that historically we don't have that much faith and trust in, that then again makes us less likely to come forward.
I mean, I can understand where that might be coming from. And I think when you are diagnosed with a particular medical condition, you end up on a treatment pathway that takes you in a certain direction that's delivered by a large organization such as the NHS. And although we as doctors believe that we are delivering the best healthcare possible for that individual, what we're perhaps not taking into account is some of the historical impact of traumas from previous generations and the lack of trust that those individuals may have in the healthcare system. So you have to, as you say, trust in the healthcare system to allow the healthcare system to look after you. But sometimes it doesn't always work and there are failings. And if that happens, that reinforces some of the challenges with trust.
It's funny you touch on the historical aspects of trust. One of the things which we covered in the first few episodes that we did for A Dialogue of Equals was the historical significance of slavery and the ramifications of what we're seeing manifested today. A key component part of slavery was the breaking down of the black man, basically taking away his masculinity. And you touched on it earlier. One of the things that have actually prevented people from actually coming forward is the fact that they feel like they'd be demasculated, or because they have a digit inserted in their anus. Now, also, what seems to be gathering speed in the conversations that I've had, particularly with my uncle, who for a long time resisted getting tested. He inspired me to get tested, but resisted getting tested because he felt if there was a negative outcome, and that is, yes, you do have prostate cancer, you are going to be emasculated because it leads to erectile dysfunction. Now, again, just breaking some of the myths, but also covering the historical ramifications. Do you think the historical ramifications are at play here? And just talk to me about the erectile dysfunction aspect of prostate cancer.
So it's a really interesting point, and like I say, I'm by no way any expert in race or racism, but you're absolutely right that prostate cancer treatment has got a bad reputation because of the side effects of treatment. And it's one of the reasons why we don't have a national screening program in the UK, is that historically, when we've attempted to diagnose prostate cancers at an early stage, it's resulted in overdiagnosis of non-aggressive cancers that are slow growing and may not necessarily affect the patient's longevity and how long they live. And over-treatment of those patients, which results in some nasty side effects, and erectile dysfunction being one of them, inability to ejaculate, and loss of fertility. And that's really, really important for young men. So what's happened recently is that we've changed the way that we diagnose prostate cancer. So we've introduced imaging. So MRI scans are now used to help identify cancers that actually do need treatment and stop us by biopsying and diagnosing men who perhaps don't need any treatment. Secondly, we've developed ways to reduce the side effects of treatment by monitoring some early cancers over a period of time. sparing some men some nasty side effects, and also develop treatments where we treat just the area where the cancer is and avoid a lot of the side effects that are caused by damage to surrounding structures, such as the nerves which control erections, and also some of the muscles that control your continence.
In terms of erectile dysfunction, that's what we're talking about. Right?
Yeah.
The treatment may leave people with a level of impotency and also leave people less inclined, right? And perhaps can speak to all that in a moment. The treatment does have side effects. I mean, we are talking about cancer, and there's a significant ailment, condition, so it's going to take serious treatment to address it. But guess what?
What?
What do you think happens if you don't address it?
You die.
You die. So we got to ask ourselves the question, right? What is life about? Life for living is not just about the physical aspects of life, right? It's really important. So it's about the relationships. It's about the people that you meet. It's about your family. There are many other ways to get on and address erectile dysfunction if that needs to be. So, I mean, we're here just talking, Professor. You will better know about some of the side effects and the impacts of the treatment for prostate cancer.
I mean, you're right, Stafford and Michael, that the prostate cancer early diagnosis, early detection and treatment has got a bad reputation because of the side effects that you're talking about. And historically, what we would do would be not really identify the cancers that needed treatment effectively. So there are some early prostate cancers that don't need treatment, can be monitored for a period of time. They're not very aggressive. And whilst others, you really do need to get on and treat. So we're much better at that now by using MRI scans to distinguish between the pussycat cancers that can be monitored versus the tigers that actually do need treatment. So that reduces the side effects, obviously, firstly. The second point to make is that we're better at monitoring the cancers over time and only treating when absolutely necessary, when the cancer gets big enough. And the third point is that we are developing new techniques to avoid some of the side effects that you're talking about. So, for example, by trying to preserve the nerves which run around the prostate that control erections, by using techniques to actually kill the cancer cells within the prostate and preserve those nerves. So these new treatments have helped to preserve sexual function for men, which is so important.
In terms of like the messaging, do you feel that there needs to be a little bit more perhaps marketing or promotion around what you've just discussed there? Because, as I say, there is a lot of apprehension because of stigma which is attached to this, and a lot of it is misinformation as well. There's nothing that I can see being put out to counter that.
Let me say, before you answer that, first, but again, early intervention, early diagnosis means that there's less intervention long term, right?
It's very nuanced these days. So, as I said, prostate cancer treatment has got a bad reputation because historically everyone thought that you would end up incontinent and impotent. But as I was saying, it's much more nuanced now that if a patient comes to see me in the clinic with prostate cancer, there are a number of different approaches that I've got that I can offer the patient based on whether they've got very early stage disease that can be monitored compared with more advanced disease that needs treatment but could potentially spare sexual function and preserve the erections versus a treatment that you just need to get on and treat immediately because you're going to save someone's life.
So if I turn up to you relatively late and I'm a stage 3 or a stage 4, as an example, you're really just going to be forced to conduct the operations that are going to save my life, I imagine.
Well, I mean, Stafford, you're not forced to do anything, but what's important is that you seek help, you come and have a chat with a medical professional, and you talk about the options. And it's a two-way process. It's my duty to explain to you what treatments are available and talk through the treatments and the side effects, and to work with you to help you find a solution that works best. And some patients will say a life without sexual function is a life not worth living, and they don't want to have treatment. Now, I would urge them that, especially if they're very young, they should have treatment. But of course, it's their choice. And they might also look at alternative treatments that are not available on the NHS. Now, of course, I can't recommend those, but we have to respect those treatments as healthcare professionals.
But even then, we would say that early detection means that then people can make up their own minds and their own decision as to the course of treatment that they follow or take up afterwards.
I think it's important to have a conversation with your doctor to talk about your risk. As I said, there are a number of different risk factors that are important. How you are going to go about getting your testing done. So we haven't really discussed the PSA test in detail, which is a blood test that we use to detect prostate cancer. We are also running some clinical trials in the UK to try and determine whether there are better tests than PSA. The PSA test is unable to distinguish between these pussycat cancers and the tigers, as I was talking about earlier on. And there may be some better tests using genetics, so a saliva test or MRI scans that might be better than the PSA test in being able to identify the cancers that do need treatment.
I like that, right?
I like that.
Hang on.
It's a worry, though, from you.
Hang on.
Go on.
I like when Prep spoke about pussycat
And tiger.
tiger.
Yeah. It worried me when he said that.
No, I really like that, because I think in most communities, in our community in particular, that most people think, a lot of people think that the diagnosis of cancer is a diagnosis of death.
Mm.
Right? So I also think that this is one of the reasons that people don't come forward, because if we're going to die, we're going to die. We don't need you to tell us we're going to die. We're just going to die anyway. And so the fact that perhaps as a professor is talking about pussycat and cancers, and I assume that they're cancers that when you see them, you think that they're, for whatever reason, you'll explain in a moment, that they're low risk and slow growing cancers. Okay, and it is really important that men hear this, that not all cancers are life-ending cancers.
But I worry because in talking about it in terms of pussycat cancers and tiger cancers, it reinforces the fact that the PSA test in particular is not very good at distinguishing which is which. So there's a psychological aspect to this, in that I get this diagnosis, I'm immediately worried, I'm immediately depressed, I'm immediately in shock because I've been given this diagnosis. But the fact that there isn't that distinction is a worry, because I may be worrying unnecessarily.
It might be a worry for a while, but then you're going to get a follow-on procedure that's going to help you to understand. And nowadays, perhaps, we're less... The digital investigation, is that totally scrapped now?
We don't use... No, you're absolutely right. And I think historically, there's been a lot of misunderstanding, stigma associated with prostate examination. I can't remember the last time I felt a man's prostate. We don't use it anymore. We use MRI scans, non-invasive, doesn't touch you or hurt you in any way. And then we do a biopsy. That is invasive, but knowledge is power, and then you know exactly what you're dealing with.
I'm glad you say knowledge is power, because it makes me think, Steph had touched on it earlier, 1 in 12 for me, is a worrying figure. If it's that big a figure, and if we are more at risk, why hasn't there been a national screening process rolled out, or even promoted, or even advertised, considering that there is that massive risk?
Yeah, it's a good question. And it's something that's been constantly looked at and lobbied for by some of the prostate cancer charities. As I said, prostate cancers screening has had a bad reputation in the past because of the risk of overdiagnosis of these pussycat cancers that don't need treatment, and a lack of diagnosis.
Sorry to jump in, but you would have learned from those. And more often than not, when you learn, you refine and you actually roll out again. But what I'm not getting a sense of is learning from previous rollouts. I'm not getting that from you, unless you're about to tell me that you're about to be very instrumental in rolling out something brand new.
Yeah, so we know from previous studies using PSA to screen the prostate cancer in communities. There was a European study that showed 15 years after initial screening, about a 20% reduction in the risk of dying from prostate cancer. So you could argue, well, why isn't PSA being used in this context? And obviously that's a conversation that's going on amongst Department of Health and within government to try and address that. Any man over the age of 50 can currently request a PSA test. At the moment, that's the threshold, but it is being looked at by the government and through lobbying from the prostate cancer charities. As far as a national screening program is concerned, the powers that be to decide on whether a screening program should take place or not. Don't believe that the data that we have so far, the trials that we've done so far, are sufficient. So for that reason, there is a national screening trial, as I was describing, that's going to test a number of different tests to see whether they are better than the PSA tests alone.
Is that the Transform program?
That's correct, yes.
Okay. And in the Transform program, they're going to look for at least 10% of those people that are tested and involved are going to be from African, Caribbean.
That's absolutely right, Stafford.
Communities.
And you raised a really good point here, because the previous screening trials haven't been looking specifically at the African and the Caribbean community. So they've been underrepresented in the trials. And that's what Transform is looking to do, to make sure that the community is represented and check that the information that we've got from previous trials actually holds true within the community, or whether other tests are also more relevant in that community.
I mean, based on the response you gave, perhaps, we understand why the government therefore might not think, or NICE or whoever it might be, might think that there's not a need for a national screening program for all men. But if black men, 1 in 4 of us are going to get prostate cancer in our lifetime, I believe that there should definitely be a national screening program for black men. Do you know that some of our members in our group, actually you do know because you've met with our group, and some of our group members recount stories of where they asked their GP to give them the PSA test and the GP declines to give it to them. I think personally that that's an outrage. What do you think?
Black Lives Matter. This is telling me the complete opposite.
And I think that's really, it's disappointing to hear, because any man needs to be informed and needs to be able to have an open conversation with a healthcare professional over the risks and benefits. And once they're fully informed, if they decide not to go ahead with testing, that's their choice, and that's absolutely fine.
Absolutely.
What you're describing, Stafford, was looking at specific groups of patients who are at higher risk and offering them screening. What we call targeted screening. And that happens is being introduced, for example, in lung cancer, in patients, for example, who are smokers. They are at increased risk of developing lung cancer. So it's whether we look specifically at certain communities and whether there is a role at a certain age group for screening. And that's something that's being explored at the moment.
You said something earlier which was worrying as well. The government aren't sufficiently satisfied, you said. What will gain their satisfaction? What is missing? Why are they not content that we do need to roll this out on a national basis? What is it that you meant by the government aren't, I think your words were, sufficiently satisfied?
So whenever a government or a policymaker is implementing a screening program, they need to look at the evidence out there. So that is what trials have been done previously, the relevance of those trials to the local communities in the UK, and also, dare I say it, the cost effectiveness of that intervention. And when I talk about cost effectiveness, we're talking about the number of lives saved. And of course, the NHS is a publicly funded organisation. and it doesn't have a limitless budget. So we need to think about how much it's going to cost. And there are some complex calculations that take place. Don't ask me about them because I'm not an expert in this area. And they look at all of this information and they decide whether to proceed with the screening program or not. But it clearly is something that is on the radar and is being looked at. And as I understand it, it is being looked at as to whether the age at which certain people can come forward and request testing may change.
Being on the radar and having something done about it, it's two different things. And it's a worry because in an earlier episode, Stafford, you talked about, and this is why I keep linking it back to slavery, the cost of treating somebody. Just reenact that for me because I want my mind refreshed, because this is what I'm hearing here. The cost of treating somebody, it's far cheaper to basically just let this person die.
I think back in earlier episodes, I spoke about the cost of a slave. £7, that was for life. Indentured labour, £7 for a couple of years. So you'd rather just get a slave and let them work them to death, and then you wouldn't get in a doctor to care for them because the money that you would pay the doctor would be more than the slave was actually worth. So that there's become a tradition where our lives haven't been valued or given the same value as others in wider society. And that's why I was saying I think we do need a Black national screening program. When Cancer Research UK asked black men why they hadn't gone for tests, 22% said the GP said it wasn't necessary. The screening programs, not just to do the actual test, but to ensure that the information and the appropriate information is going out there, informing people. And then, as Prab said, once people are informed, it's up to them to make informed decisions.
So do you see contextually why we are up in arms, as it were, when you look at the historical context and how it's actually playing out today? It's very, very similar, right?
I mean, I've been really educated by the time that I've been spending with Stafford and his group and through the conversations that we've been having today, because that I'm not an expert on race or...
That's why it's a dialogue of equals.
But yeah, I can understand why it's a very, very challenging area to be looking at. And, I'm hoping in the near future for a change.
Excellent. And, one of the things, thanks for that ever so much, perhaps. And maybe we can get you to have a little dialogue with some of our other guests here. Because one of the things about cancer per se, and we're here to talk about early detection, but there's this thing about the stigma of cancer within our communities that we don't really speak about it much. My mum, who I talk about often, and a lot, I'm proud, I love her, right? And I love my dad, right? When my dad got, and my mum was quite an educated person. She was, I've always bragged that she was the first black female shop steward in the history of Ford's Motor Company in this country. So she represented other people. When my dad had prostate cancer, some 2000, right? He got it, right? My mum said that she was worried about him coming home and sleeping in the bed beside her because she felt she might catch his cancer.
Wow.
So there's a whole heap of ignorance, the lack of awareness that exists within our communities, and mainly because we just don't talk about it.
Yeah?
Because we don't access services early enough, we access services late, so the outcomes are not always good, and those who do access services do not always talk about it. So I'm really chuffed that we have today with us some of our group members. We've got Lloyd Gardner and we've got Derek Brown, both of whom, I'm really pleased to say, has survived having to deal with bouts of cancer, various forms of cancer. So, Mr. Brown, good to have you with us. Derek and I, we went to school together. You're a year older than me, and I know that you've had some health issues that you've had to face. Can you tell us about your fight and your fight against cancer in general, not just prostate?
Yeah, in 2018, around April, I was diagnosed with bladder cancer.
Bladder cancer.
Yeah. At the same time, they said, as the doctor explained, the bladder and the prostate are very close together. So I was checked. They said it was a swelling, and they should deal with it. Instead of having one operation and going back to go and do it, they might as well do it now. So I went through the process of having my prostate removed, and also they dealt with the bladder cancer. At first, it was a bit worried because there was a slip up and they were saying it was a bowel cancer. In fact, it was my bladder. The treatment I went through, I took I had chemo, and I heard some of the statements you were making about shrinkage and things like that is true. The chemo, they've explained to you, you'll have chemo brain with your memory. There's a lot of things tied to it. But anyway, I'm a person who goes to my doctor. I'm not that person, if you got a car and something's wrong, you go to a mechanic, a doctor. So I've gone to my doctor, and it was from a little sign which I saw. I was lucky to see a little sign in my urine, and it led me to pursue it. And they treat me pretty fair.
So you was diagnosed relatively early.
Yeah,
Okay.
diagnosed early.
It's critical, right?
That is the thing. If you got it early, you diagnose early, it may be a savior. But some of us just sit back and hope that it'll go away. It's not a thing that's going to go away. It'll increase a bit, if anything else. And like I said, it was in April, and by September, I was going for surgery to remove the bladder. And it was an 8-hour surgery, which they done both at the same time. I was treated pretty fair, I think. I didn't really see no racism, but I could see at times, there was one case where my first consultation, and this doctor was there, and I won't mention the names, and she was busy with she was telling me what's going to happen, and busy with her texting her, someone's texting her, and I nearly blew my top that day, because you're worried. It's your first time. My first consultation, I'm sitting there and I'm worried, and she's thinking, is there any value to my life? I was thinking here,
You're not giving you the attention that you definitely were due. And just on one thing that kind of jumped out at me, you were saying that what we've been discussing up until now in terms of side effects, in terms of what actually happens, I wondered how you actually dealt with that. We spoke about not necessarily remedies, but ways in which you can live with the fact that, you do get reduction, you do get the other side effects.
Yeah.
So how did you deal with that?
That's a good question, because I done everything on my own. There was no one else, which is, it was hard. But, I'm a strong-minded person, so just had to go for it, and taking as much information as I could. And that was kind of strengthened me up. There was times I'd think, do I go through this? Do I continue with this? But once started, I couldn't just say, no, I don't want it.
There's nothing like life, right?
No. So I just went through with it and pursued. And in the end, I'm still here. So, I have no regrets in going there early for myself. And that's what we need more of us to go and get checks. We're talking about screening. We have a screening for bowel cancer at 50, don't we? Nationally?
Yeah.
Right. So we should have one for, they know in the that is 1 in 4 for a black man or black ethnic minority. We should have a screening test going for us. Once we get to a certain age, unless you're in mid-30s, I think, going up.
I saw a statistic that said prostate cancer, for example, they spend the most money on out of all cancers, £320 million per year on prostate alone. So you would have thought that even that would have justified having a screening program. Lloyd, you too have a story of early diagnosis. And again, I remember talking to you and you had just seen an ad or seen something that then made you see you should go have yourself checked.
Yeah, that's right. Yeah. Well, I was watching breakfast TV and they were talking to some sportsmen who had it and decided that if you're black, you're over 50, you stand the 1 in 4 chance and you should get tested. So I thought, well, I should do, because I owe it to my family. And, if I sat down and ignored it, and then later I got it, how would I tell them that I knew I could have this thing? So I just decided I'd go and see the doctor. And the doctor was very good. They put me, I did the PSA test. And then I thought, okay, I've done that then. And I booked my holiday and I was going to go away. And then I received a call from the doctor saying, your numbers are a bit high. And she said 4 was a norm, 1 to 4 is okay, but mine was 6.9. And we suggest we need to investigate it further. So you should cancel your holiday and do it straight away. And I did. And I then had an MRI scan. And then the result of the MRI scan was that I needed to have a biopsy because they still weren't sure. So I had the biopsy, and then as a result of the biopsy, they then said, yes, you've got cancer. And the numbers shows that it's not an aggressive one, so you've got various kind of treatments that you can have. And really good. The NHS were really good, I feel, at this time. I saw 3 different consultants who then taught me through the different kind of treatments I could have. And I was then given the choice of which one I should choose. And I did. So, but what happened was each one I chose as a thing after going through the different consultations, they said, oh no, you can't have that one.
What was the point of the choice then?
I think, no, because where the cancer was, it's situated, and I only had one option really, which was the radiotherapy.
So all the side effects then, one of the radiotherapy, I take it there were side effects. And what did you use or what was the path for you in terms of treating the side effects? I mean, I keep hearing of pumps and tablets and lotions and potions. What worked for you?
I didn't have any of those side effects because I think they vary to different individuals. And at the start, when you're having a radiotherapy, it does kind of give you those side effects, but I didn't really worry about it in essence. And as you go on, it gets better. And I think certain things come back.
Why I'm asking, because I thought you were talking about you did have side effects. So how did you actually, because to me, sex is important.
Yeah.
If in order to do that, then you'd have to either take the pump or the pill, no?
Yeah.
Or again, being frank and open and honest, were you more concerned about surviving than the sex? Because me, if I was put in that situation, I'd be into the sex and survival, but sex is kind of like up there and survival is kind of like a little bit under it. I'll be honest.
Okay. As you see different decades, I think it's easy to say that when you're not facing an illness that can actually be life-ending.
I hear you.
I think once you get that diagnosis, the world changes in the way that you see and engage with that world change.
So sex is low the balls.
Yeah, of course I understand that that's an enjoyable activity on most men on a daily basis. I think, Lily, have you? Are your children going to be watching this? I think ultimately, we have to give thanks to life and we have to do all we can to survive. And what Lloyd was saying is that you survive first and then you take on all the other issues as they come.
Okay, I hadn't actually considered that because in my kind of like mind sphere, I'm thinking in terms of life enjoyment. I'm thinking in terms of maintaining the norms. So continuing those norms, I'm thinking, okay, what can I do to actually address that? But it's like what Stafford was saying for you, right? That it does help you reevaluate, or you definitely do reevaluate your life. Is that right?
Yeah, that's right. Because what happened, I had this. So it was over like a year, the treatment, because the first part of the treatment was to get some hormones. So I went to the Royal Free and they gave me hormone tablets to get the prostate to a situation where they could then zap it with the radiotherapy.
I'll just check with Prof what kind of hormonal treatment that might be.
So there's different types of hormonal treatment that you can give for prostate cancer, but typically the one that's given with radiotherapy is an injection that suppresses the testosterone levels. So that's the male hormone. Male sexual hormone. So that's suppressed for a period of time before and during the radiotherapy, and in some instances for a period of time afterwards.
Okay, so what we're really saying is that if you're suppressing the testosterone, is the testosterone that is the manly hormone, right?
That's correct.
Right. So there's going to be a natural cessation or
Lack of desire.
absolutely.
Right. Okay.
And that might then mean that you'll focus on obviously living on an hourly basis. You might focus on survival first.
Hey.
Yes, and then then having the therapy was also very good, and I have to say thank the NHS at this point, because one side gone through the stage before the radiotherapy. Then the radiotherapy was like a month long, every day at a specific time at the local hospital, and I'd go in there and lay down on the machine, and they would do what they had to do. But it was really good. In essence, the people that were performing the radiotherapy were just very caring and very supportive and just very nice.
Lord, we hear about radiotherapy. What does that look like in practice? I've got no idea. I'm trying to picture it in my mind. I haven't a clue what radiotherapy looks like.
Okay, well, it's painless, and I was worried that they didn't have the machine switched on, because I would go in there before the session started.
Right.
They do a scan and they mark your body where they're going to target, and then it would be you have to drink a lot of water before you go in so that your bladder's full, and then I would lie down on the machine for like 5 minutes, and they would do what they would do, and then that would be the end of it. So it was told, I would just come back and go to work.
Didn't feel a thing.
Didn't feel a thing. And, as I say,
The wonders of modern
medicine. You think it could going to be, something is going to be more sort of problematic or sort of hurt or intrusive. Yeah, no, it was. It was just like, just come lie down here, take your clothes off. That was the worst part, having to take your clothes to the nurse, but I got used to that. And then it was fine.
No burns?
No burns, no nothing. No,
Well, it's not, sorry, if I can interject, I think a lot of men who have radiotherapy find the hormone treatment more problematic than the radiotherapy help. Is that correct, do you think?
Yeah, I think that is correct, because it did explain to before that your sex drive would slow down.
Yeah.
All right. I thought you were talking about the way it was administered, but are you just talking about the side effects? Right.
So it puts you into a sort of menopause type state. So loss of libido can change your weight.
Yeah.
Make you a bit tired and lethargic at times.
Right.
There are some,
No.
there's some newer forms of radiotherapy that are being used now where you don't need any hormone treatment at all. That's quite appealing for some patients.
Hopefully that'll be developed by the time that Michael reaches a certain age, and should he need it, it will mean that he'll be able to continue with his other interests. whilst undergoing treatment. Now, we've spoken about the benefit of early detection, and both Derek and Lloyd are absolute examples of those benefits. But Probs, tell me something. Is there anything we can do as men to stop us from getting prostatitis or prostate cancer in the first place?
At the moment, no. So it's not like prostate cancer that we know is caused by a virus or a disease or anything like that. It's nothing that we can do in terms of changing our diet or stopping smoking. We just need to live a healthy lifestyle and be aware of the risk and be aware of our own personalized risk based on our ethnicity or our family history. That's all that we can do right now.
I'm quite interested in the self-diagnosis and bringing yourself to your doctor because you feel that there is an issue. I know myself, I'm very, very in tune with my body. I'm very, very clued up on when something is definitely wrong. But what I'm terrible at is talking about it, bringing it to the doctors. What would you say are the key signs that you need to be worried?
I mean, this is a really, really interesting point because early prostate cancer doesn't cause any symptoms.
Silent killer.
It doesn't cause any symptoms at all. Now, so as you get older, your prostate enlarges. I mean, I don't know how old you are, but usually as you get older, your urinary flow reduces. You can't pee up the wall like you did when you were 16 years old. You might have to get up at night once or twice, and you might have to rush to the toilet. That's because of benign enlargement of the prostate. That's not usually caused by prostate cancer. But benign enlargement of the prostate is something that men suffer from as they get older anyway.
Right.
And your risk of being diagnosed with prostate cancer increases as you get older. So there's been some studies that I've done in the past where they've looked at post-mortems of men in their 80s. And in some groups, about 80% of those patients will have some underlying prostate cancer, but it may not be an aggressive form of cancer. So prostate cancer and benign enlargement sometimes goes hand in hand.
Right.
But just because you've got urinary symptoms doesn't mean you've got prostate cancer. And similarly, because you've got no symptoms at all, doesn't mean you don't have cancer. So it's an awareness of risk rather than being reliant entirely on symptoms, which could be misleading at times.
So for me, for example, because my dad died of prostate cancer, I make sure that annually I go and have a checkup. And my trigger's my birthday. Every time I have a birthday, I remember to call the doctors and go and have a checkup. And then ultimately, that's what we're trying to say to all the men who are listening to this podcast today.
Yeah.
We're saying go and get the check, get the information, find out whether or not you really are at risk of having prostate cancer, whether you have it or not, and then make informed decisions. So knowing then at least gives you the opportunity of making informed choices.
Yeah.
Right? Yeah. I think on that note, I'm going to thank our guests. You've been really, really excellent guest. I don't know if there's anything else that any of you want to add, any messages that you want to give to your peers about how they might look to towards protecting themselves and protecting themselves going forward.
Get yourself checked. That's the main thing. The stigma's gone now of the digit. So it's safe. You feel more comfortable. Get yourself checked. That's my main point.
Absolutely. Lloyd?
Yeah, I would just agree with Derek there. It's important, because you choose in life. So for the little inconvenience that you may feel is there, which isn't there anyway, I would start off and go and get the test, the PSA test, and then you can make a decision from there.
Choose life.
Choose life.
I like that. Well, with that, I think that's been a great program. It's been really good to listen to the professor give us the scientific understanding of what prostate cancer is. And
very insightful.
That's the body, but it's also really important that we've spoken to people who have been treated successfully for those conditions and who are thriving and enjoying life.
Living well.
Yeah. And Derek, I mean, both of you, we should say you're both back at work and you're both living full active lives again, right?
That's right.
That's excellent. Brilliant. Bit more power. So once again, I just want to hand over to our guest, Professor Prof Rajan, just to explain and contextualize the benefit of early detection when it comes to not just prostate cancer, but any cancer, basically.
Stafford, thank you, Michael. Thank you. I mean, Stafford, you raise a really important point here that, in general, identifying a cancer at early stage will improve survival. So, to give you an example, lung cancer, if it's diagnosed at stage 1, the survival rates are over 50% at 5 years. But in contrast, if it's diagnosed at a late stage, stage 4, the survival rates are less than 5% at 5 years. So that's a real stark contrast in outcomes for patients based on how early or how late the disease is diagnosed. With prostate cancer, the story is a little bit murky because some of the historic evidence that we have using PSA, which is a blood test that we use to identify prostate cancer at an early stage, and the screening studies that have been done with PSA. And there's one study which shows about a 20% reduction in death from prostate cancer about 15 years after screening, a European study of almost 200,000 men. But one of the controversies around that study was the fact that a lot of cancers were identified that didn't need treatment, and some of those cancers were treated with side effects that we've been talking about earlier. So there are some challenges, and that's why there isn't a screening program at the moment in the UK for prostate cancer, and some ongoing research and clinical trials to try and identify the best test to screen men for prostate cancer.
I've said it before, and I'm going to say it again. We're no expert when it comes to a lot of the issues that we've been discussing in this series. One of the things that always perplexes me is we talk about stage 4, we talk about stage 3, we talk about different stages of cancer. What does that actually mean? Just give us a quick overview of the stages.
So the way that cancer is staged depends on whether it's localized to the organ in which it originates. So in prostate cancer's case, it's the prostate gland, which is a small gland which sits just below the bladder in front of the rectum and below the pubic bone in the pelvic area. And cancers that are localized to the gland, early stage cancers, stage 1, stage 2 cancers, they have better outcomes. But when cancers start to spread, and that could be to adjacent organs or to lymph glands or to the bone or the brain or the liver and other areas, they're generally classified as more advanced stage.
Right.
Stage 3, stage 4.
And stage 1 and 2 are operable, and stage 3 and 4 often are not operable. Is that right?
So generally speaking, the role of surgery, which is what we are talking about here, is for early stage disease. So the idea of surgery, in most cases, is to give a patient the best chance of complete cure with a single treatment by complete removal of the gland or organ where the cancer has arisen, or removal of just the tumor in some instances.
And that's why when it spreads, if you turn up late, it's far more difficult for them to operate, and you're more likely. I mean, you get less options basically if you turn up late.
No, that's right. And the role of surgery in patients who have got cancer that spread to other parts of the body is more controversial and not that well established as it is for tumors that are localized to the gland.
And again, this is even more reason why we're really saying to the brothers out there in particular that we need to take responsibility for our health. We need to just go and have checkups. We need to go and have the tests. we need to give ourselves the best opportunities for survival possible. And now we're going to have my brother called Kirk. Kirk, he's going to give us, Kirk's story, it really is a tragic story, but I'm really pleased that you can be here with us today. And there you have the integrity and the inner strength to be able to share your story with us, because you do so with the hope that it might inform and help others in future, right?
Most definitely.
Okay. So the floor is yours.
So where would you want me to start? Because
so we're going to tell a story about your dad, unfortunately, not here with us today.
Because he had cancer twice, right? So he had prostate and he had lung cancer.
Right.
Yeah.
So in some senses, tragic that he went through 2 different kinds of cancer, but he epitomizes exactly what we've been speaking about today, okay? So the early detection, you do have a chance, late detection. Tell us your story. Tell us your dad's story.
So my father now, back in 2007, I believe the month was even October, he had a car crash which writ him off totally. And within that time, they told him he was on a walk again, which he actually was able to do eventually. But due to him being in the hospital, they found out, obviously, with the accident that he had cancer, and it was prostate cancer, but it was at a very early stage.
Sticker pins. Let's say your dad's name, right?
Evan Brissett. Oh my gosh, I didn't even say my father's name. Yeah, Evan Brissett. So what happened is now they found it and detected it extremely early. And I usually hear horror stories of people passing of prostate. So I think he was a little bit worried at the start, but because he caught it so early, they managed it. He went through the physiotherapy. Sorry, not physiotherapy. The therapy. What is it again? Radiotherapy. I'm going mad. Radiotherapy. He went for a long period of time until he had the all clear. And this was like a couple of years it took. And then I believe it was last year, January, he was diagnosed with lung cancer. But the problem is for about a year, he was going to the doctors and they were just saying he had a chest infection. They were giving him antibiotics and they weren't really checking for anything. And it's only the month before the January, so it was December 2022, he just rang me and said, don't really feel too good. He ended up going to the hospital and then it was kind of giving signs of lung cancer. And then by the next month, they confirmed it. And then it was by February last year that they actually cut a third of his lung. And then they were supposed to do the radiotherapy after 7 weeks of it being healing up, as in cutting out the third of the lung. But then, I'm sorry to say it about the NHS system, but they completely just forgot about my dad. So as in 7 weeks went past, and then I think it was a good month on top of that, he's gone back to the doctors, and then they saw that his blood levels were high. He was in the hospital for a month, and then by, June last year, he passed. So they did, I don't know what stage they caught it at, but they caught it at a stage where they could cut off a third of his lung, which happened in the February. But then obviously, by the time that they left it for so long, the actual parts which was supposed to have radiotherapy ended up taking over, and it just got out of control where they couldn't do nothing about it. But the craziest part I find is that the doctors themselves sent him home for a year, giving him medication for an infection in his chest. He'd done a lot of tests. They said, it's just an infection you got on your chest, just an infection. For the whole of 2022. I think even before that, actually, it was in lockdown. So it could have even been in 2021. They were saying, he's got a chest infection, take these antibiotics. He's got this terrible cough, he's smoking. Things ain't seeming too right until his lungs just completely gave up on him. And so crazy.
It's interesting from what you've said there. I wanted to kind of get a sense of where you came into it in terms of support, because why I'm so pleased that you're sitting on the couch there is that I said this earlier in an earlier episode, that it's really important that families recognize how they can help, how they can support, what role they have to play. I want you to unpack that for me, because I know from my own experience, I'm terrible at support because I don't feel there is a role for me. What role was there for you?
So role for me, I would say, just being supportive and being there. I think that's the key thing, supportive. I feel like, cause my dad is like, he's that kind of, he takes care of everyone. So it's like, we're always thinking, even in the times when my dad's a very proud person, that even in the times he would still try and manage and do things for himself, all the way to the end, so I think a part of that was at the back of my head where I felt like after the 7-week recovery time, we should have been pressing, but I think we were just waiting for the hospital to get back to us. And I'm thinking my dad had it under control, and then it turned out they just didn't even send a letter back to even do anything. And they just gave him the operation. They said 7 weeks, come back in recovery. And it's just like, after 2 months has gone past, we ain't heard nothing. We're going back to the doctors only until the last moment they said, oh, yeah, sorry, we forgot. I was just like, huh? And this was like, they literally said that probably about 6 days before he passed. Like, oh gosh, that was our bad.
Condolences.
Yeah.
One of the things that we talk about is about people advocating for their own health needs, but others as well, when people are sick, being able to advocate on the behalf. I mean, obviously, there's not much I can ask you about that particular instance there, perhaps. But again, there is something about the benefit of early diagnosis, right? I mean, here we can't talk about what happened into the NHS during the pandemic. Obviously, went into a bit of a meltdown. That meltdown and the impact that we saw then is still, there's still a residual memory of that within communities, and it still goes towards that sense of distrust that we have, because many of us feel that we didn't necessarily, and we haven't always received the best service from the NHS possible. Is there anything you can say to that, perhaps? I don't know, make out that you're responsible for that, but
no, I'm sorry to hear. It's a really tragic story, and
blessings.
Must have been really, really difficult for your dad and for the family. I mean, I think, going back to our discussion point about risk, you mentioned that your father was a smoker, is that right?
Yeah, he was a smoker, yeah.
Yeah, so smoking obviously is a risk factor for lung cancer, so it's an important risk factor to be aware of if you do smoke and you have symptoms, and to get checked, and if you do have symptoms. As far as the way the NHS works, I mean, it's not a perfect system, unfortunately. It's there are sometimes failings, and I hope that in this instance they investigated properly and were able to give you some answers as to what happened.
Mm-hmm.
Where you do have a failing like that, it's a pretty catastrophic failing, how things have actually transpired. What are the reprimands for that type of activity? Because there is clearly something which went catastrophically wrong there.
It's difficult to know what happened in this particular case. Obviously, I don't have the details, but the process is normally in the NHS where things don't go to plan is for there to be an internal investigation.
Right.
To try and identify where mistakes happened, if any mistakes did happen.
What prompts that there? Because unless I'm mistaken, it sounds as though the conversation was a localized one and wasn't actually escalated to any level.
I think it's difficult to know what happened in this instance. But generally speaking, when things don't go to plan, and that is that patients maybe don't receive the follow-up that they should receive, or they have a complication from a treatment, there is normally an internal investigation to try and understand why that happened. What are the learnings from that, and to try and avoid it happening again. But unfortunately, it's not a perfect system. And I think it's important all around that there is a reflection, and to try and avoid it happening again, try and avoid other patients potentially suffering.
Thank you. Kirk, thank you for sharing that story for us.
Thank you.
In another episode, I'm going to talk about my own personal experience with early detection, and I was really super lucky. Like Kirk's dad, I smoked for 40 odd years, more years than I care to remember. I smoked hard, 40 a day and such. And I was given an early diagnosis of precancerous cells in my lungs. But just by knowing, I mean, it was so informative, educative. I was then able to do my own research and work out what I could do for myself, for my health, without having to go through the evasive treatment that the NHS was suggesting at the time. And we'll talk about that in another episode.
Tremendous.
So we're also going to talk to my good friend, someone I went to school with. His name's Horner St. Catherine.
Okay.
Who was also given has also had diagnosis for cancer and is living with it and dealing with it and managing it in his own way. I think that's a positive way that we're going to end this program.
Can I say one more thing? I think the key thing for certain viewers that need to understand is that what I've learned from the system, from this experience about the system, is that you just can't 100% rely on them. Like, you have to map it out yourself and you have to be on them. Like, and you can't really, if your body feels something, like, you have to push the extra step to go and see. Like, so don't really always take the doctor's word on it. I'm sorry to say that. I'm not to cuss or bash the doctors at all, but they failed my dad in a very catastrophic way. Not just the doctors, but the hospitals too. And it was a whole chain of events which could have been heavily avoided. So, I mean, if they sent him in for the early checks, something could have been done correctly. And I don't still understand how you could operate someone and not follow up, knowing that you're telling us that he's gonna have to have the therapy on him, and then nothing ever comes of it. And then the worst part was, which I really thought was a bit crazy, so that which really sunk in the moment, is my dad. So it was a Monday, so he passed on the Saturday, 10th of June. But on that same Monday, that same week, the doctors literally sat in front of us and said, "Yeah, it's our failure on our side." And that was it.
Wow.
So how are you going to punch the doctor in the face? They're like, "What do you mean it's your failure? Is that it? Is the best you're going to say? There's not really, Yeah, a couple of days. Sorry.
And life is gone. Sorry isn't good enough.
It is not.
What you need to do is take some kind of a formal complaint.
Yeah, my dad was definitely pressuring me for that, yeah.
So that there's a formal process. So there is some learning within the systems that I don't go through this again. But again, what it really makes us say is that people have to develop the knowledge so that they're able to advocate for themselves that are inside that system. Can I thank you, Kurt, for your involvement?
Thank you for having me as well.
Okay. For sharing your story.
And RIP to my father, Evan Brissett, every time.
RIP.
God bless.
And thank you once again, Praps. Thanks ever so much for both of your input today. Thank you.
Take a step, go, get checked. Want the best for you, no less. Stubborn head, make it make sense. NHS before it goes left. Me and my unks had a dialogue of equals. We're tired of all our people dying before they seem to. Silence don't make you peaceful. So many open wounds, don't even know how we'll heal all. But this is food for thought of a meal. It might be a free course. You know the usual 9 nights and funerals, high and by at the graveside like time is recuperable. Ignore the treatable symptoms, these will cause a domino effect. You won't make it home to the loony board. Take a step, go, get checked. Want the best for you, no less. Stubborn head, make it make sense. NHS before it goes left.
Any information provided on our podcast series is for educational purposes only and does not substitute for professional medical advice. We advise listeners to consult a medical professional or healthcare provider if they seek medical advice, diagnosis, or treatment. We value different opinions and experiences in our program, and any information shared by our guests should be seen as their personal opinion. We have guests who are medical practitioners, but we do not have a medical doctor on our production team. We've added extra information from reputable sources on our website if you want to inform yourself further. We strongly advocate for everyone taking responsibility to inform ourselves about our health. We cannot be liable for risk or issues associated with using information discussed during this program.